Hi everyone, it's Heather Vernillo and welcome to week 3, and we're going to review some of our psychotropic drugs this week. We're going to talk about classes of drugs that can alter behavior and promote sleep, going over the uses and the actions of these drugs, the pharmacology behind them, the absorption, distribution, metabolization, and excretion, and different drug interactions and adverse reactions to these particular medications. So you have your sedatives and your hypnotic drugs, and a sedative reduces your activity level. It reduces tension, reduces excitement. Some degree of drowsiness is very common with sedative use. When given in large doses, sedatives are considered hypnotic drugs. So they induce a state resembling sleep. There's 3 main classes of synthetic drugs that are used as a sedative or a hypnotic. And those are your benzodiazepines. You'll see those written as BZDs or benzos, your barbiturates, and then your non-benzo drugs. So benzodiazepines produce many therapeutic effects, also sometimes known as chill pills. Things in this realm, like a Xanax, sometimes on the street, they're called like a bar of Xanny. So you might hear patients say these things. So we have drugs that end mainly in LAM and PAM is where you'll see these when we look at the generic name. So alprazolam, lorazepam, tenazepam, things like that. So benzos are absorbed rapidly and completely from the GI tract. They're absorbed rapidly in the GI tract, distributed widely throughout the body. Penetration into the brain is very rapid. The rate of absorption determines how quickly the drug will work. The duration of the effect is determined by the extent of the distribution. Triazolum is highly lipophilic, and it gets very widely distributed. Therefore, it has a very short duration of effect. Benzodiazepines are usually given orally, but may be given parenterally in certain situations, such as when a highly anxious patient needs sedation. All benzos are metabolized in the liver, and they are excreted primarily in the urine. Some benzos have active metabolites, which may give them a longer action. Most are short-acting, such as Xanax, which usually hits its peak effect and leaves the system in about 4 hours, which is why it has very high abuse potential and why someone would have the effect wear off in 4 hours and want to take another dose of the medication. Researchers believe that benzos work by stimulating the GABA receptors in the RAS system of the brain. Going back to anatomy and physiology for a second, remember your reticular activating system. The RAS is associated with wakefulness and attention and includes our cerebral cortex and our limbic system, thalamic and hypothalamic levels of the central nervous system. Now, how do they work? The speed of impulses from the presynaptic neuron across the synapse is influenced by the amount of chloride that is in that postsynaptic neuron. And the passage of these chloride ions depends on the inhibitory neurotransmitter called GABA, or gamma aminobutyric acid. When GABA is released from that neuron, it travels across the synapse, it binds with a GABA receptor, and this binding opens the chloride channel, allowing the chloride ions to flow into the neuron, causing the nerve impulses to then slow down. When given in higher doses, benzodiazepines can induce sleep, probably because they depress that RAS system in the brain. Benzodiazepines increase total sleep time and produce a reduced number of awakenings. In most cases, benzodiazepines don't decrease the time spent in REM. It Sorry, I had a cough for a second. Most cases, our benzodiazepines, they don't decrease the time spent in your REM sleep. And you remember, your REM sleep is that state of sleep in which the brain activity resembles activity when you're awake. The body's muscles relax, the eyes move rapidly. This gives benzodiazepines a significant advantage over barbiturates. So let's talk about one of the most popular benzos, which is alprazolam or Xanax. The action of this medication is that it enhances or facilitates the action of that GABA. It acts at the limbic, the thalamic, and the hypothalamic levels of that central nervous system, which produce an anxiolytic, a sedative, hypnotic, skeletal muscle relaxant, and anticonvulsant effect, which leads to central nervous system depression. Indications of use are for anxiety and panic disorders. Nursing considerations is that we're going to monitor the patient for adverse reactions, such as drowsiness, dry mouth, diarrhea, or constipation. This drug is not recommended for long-term use, and we don't want patients to withdraw from the drug abruptly because seizures could result. Now, pharmacotherapeutics, remember that's how the drugs are used, include relaxing the patient before surgery or a procedure. So if someone's going in for LASIK eye surgery, they might get a dose of Xanax prior to going in. Someone who is claustrophobic might get a dose before they have to go into an MRI machine. They can treat insomnia. We can treat alcohol withdrawal symptoms, treat different seizure disorders, and promote skeletal muscle relaxation. For drug interactions, unless it's another CNS depressant like alcohol, there are few drugs that actually interact with benzos. Triazolam may be affected by drugs that could inhibit the particular cytochrome that drug works on. Something maybe like in the mycin family, same things that affect methadone, erythromycin and ketoconazole. Those could cause a longer QT on an EKG. When benzos are taken with other CNS depressants, the result is an enhanced sedative or a depressant effect. So that can reduce level of consciousness, reduce muscle coordination, could cause respiratory depression and death. Hormonal contraceptives may reduce the metabolism of some of the benzos, which could increase the risk of toxicity. So adverse reactions, what could happen when you're taking benzos? Amnesia, fatigue, muscle weakness, mouth dryness, nausea, vomiting, dizziness, and ataxia. And benzodiazepines with a longer half-life or active metabolite could accumulate and cause adverse effects in our elderly patients and should be avoided. And if they have to be used in the elderly population, we're going to start the patient at the lowest dosage possible. So doing our nursing process, starting with assessment, what are things that you think you would assess for? Patient's anxiety before therapy and after. In the patient receiving repeated or prolonged therapy, we want to monitor liver, kidney, and hematopoietic function tests. We want to assess for adverse reactions and drug interactions, and we want to make sure that they have knowledge of their drug therapy. Key nursing diagnoses would be anxiety related to patient's condition, risk for injury related to the sedation, and deficient knowledge related to drug therapy. Our planning stage of the nursing process, we will have the patient state that their anxiety is reduced. The risk of injury to the patient will be minimized. Patient and his family will demonstrate an understanding of the drug therapy. So implementation. We don't give benzos for everyday stress, and we do not use them for long-term therapy. We check that the patient has swallowed the pills before we leave the patient's room. We give lower doses to elderly patients, and we don't withdraw benzos abruptly after long-term use because the patient could go into withdrawals. And abuse and addiction is very possible with this class of medication. Now let's just talk a little bit about our mood disorders. Now we have unipolar disorders, and this is categorized by periods of clinical depression and are generally treated with SSRIs, which are selective serotonin reuptake inhibitors, MAOI inhibitors, and TCAs, or tricyclic antidepressants. And two poles, or bipolar, is characterized by alternating periods of manic behavior and clinical depression. Generally treated with antipsychotics and things like lithium or anticonvulsants like Depakote. SSRIs were developed to treat depression with fewer adverse effects, and they're chemically different from TCAs and MAOIs. Some of the most common SSRIs you are going to encounter in your clinical setting are citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. SSRIs are absorbed almost completely after oral administration and are very highly protein bound. They are primarily metabolized in the liver and excreted in the urine. And SSRIs, just like the name says, inhibits the reuptake of the neurotransmitter serotonin. SSRIs are very useful in treating panic disorders, eating disorders, personality disorders to a degree, impulse control disorders, and anxiety. For example, paroxetine is indicated for social anxiety disorder, and fluoxetine is approved for the treatment of bulimia. Fluoxetine and sertraline are approved for the treatment of premenstrual dysphoric disorder, and many of them have an indication to treat obsessive compulsive disorder. Paroxetine and sertraline have FDA indications for post-traumatic stress disorder. And drug interactions with SSRIs are associated with their ability to competitively inhibit a liver enzyme that is responsible for the oxidation of numerous drugs. So if using an SSRI with an MAOI inhibitor, that will cause some serious, potentially fatal reactions. Individual SSRIs can have their own interactions as well. But if a patient is going to be transitioning from one drug to the other, most psychiatric nurse practitioners and psychiatrists will, depending on which drug they're transitioning from, it's usually about a 2-week period for the half-lives to get out of the system before you can safely start a different medication. And if you've ever read the back of any over-the-counter medication, there's always a warning on there saying, do not take this if you are taking an MAOI. So using citalopram and paroxetine, if you mix any of those two with warfarin or Coumadin, it can actually increase the bleeding. Carbamazepine can increase the clearance of citalopram. And if you're taking fluoxetine, it will increase the half-life of diazepam and displace protein-bound drugs, which will lead to a toxicity. And paroxetine shouldn't be used with tryptophan because this combination can cause severe headache, nausea, sweating, dizziness. Paroxetine can increase procyclidine levels, which will actually increase their anticholinergic effect. And paroxetine and sertraline may interact with other highly protein-bound drugs, which will cause adverse reactions to either drug. So it's very important that patients let you know what medications they're on, because this guides your providers in choosing the right course, because some of these drugs can't be mixed with certain antibiotics or other treatments because they can actually be an inducer or an inhibitor and cause a toxicity of either of those medications. So anxiety, insomnia, somnolence, palpitations can all occur with the use of an SSRI. Sexual dysfunction is very common with the use of SSRIs, as well as low libido. Decreased glucose concentrations in the plasma can occur with the use of fluoxetine. And orthostatic hypotension can occur with citalopram. Now, all of these drugs do carry warnings for suicidal ideation and aggression. And it's very important that patients be educated that most of the side effects or symptoms of issues are going to occur. They're going to occur in those first 2 weeks. And they really should ride it out, because most things like GI upset, nausea, diarrhea, things like that will be gone by day 14. However, a truly depressed person who doesn't have the energy to commit suicide, who suddenly gets this flow of serotonin and energy into the brain, could then be ready to complete their particular plan they had to end their life. So it's very important that patients who are started on these medications be watched for those first 2 weeks. We should never, ever, ever abruptly discontinue any SSRI, because there is a thing called SSRI discontinuation syndrome, and that's categorized by dizziness, vertigo, ataxia, nausea, vomiting, muscle pains, fatigue, tremors, headaches. It's a true withdrawal. They could get psychological symptoms, crying spells, irritability, sad feelings, memory problems, vivid dreams. And SSRI discontinuation syndrome occurs in up to about 1/3 of patients taking SSRIs. It's even worse when they're taking an SNRI. But it's definitely more common in patients who take an SSRI that has a shorter half-life, like paroxetine. Fluoxetine, Prozac, is less likely to cause this problem because it has a lot longer of a half-life. And when we're doing patient education about the MAOI inhibitors, your biggest teaching points and things that you're going to see on your NCLEX is going to have to do with what can you eat, or what education would you teach your patient in what they could eat if they are taking an MAOI. So the most serious reactions involve something called tyramine. And tyramine-rich foods are things like red wine, fava beans, and aged cheese. Those will cause a severe reaction. There are some ones that have moderate tyramine, like bananas, but usually that one is not on the NCLEX question. They usually specifically look at that red wine or the aged cheese. Caffeine can also interact with MAOI inhibitors, but the reactions aren't as serious. And if the question asks you what could happen if the patient were to consume these products, it's that it would produce a hypertensive crisis. Your other class of drug is called a TCA, or a tricyclic antidepressant. Common ones are amitriptyline, or doxepin, or nortriptyline you might see patients still on. All of TCAs are active pharmacologically, and some of their metabolites are also active, and they're completely absorbed when taken orally, but they undergo a very fast first pass effect. And researchers believe that TCAs increase the amount of norepinephrine, serotonin in both in the CNS by preventing their reuptake or reentry into the storage granules at the presynaptic nerves. And preventing this reuptake results in increased levels of these neurotransmitters. So it relieves depression. It can block acetylcholine. It can actually block the histamine receptors as well. And TCAs are very helpful when they're paired with a mood stabilizer in treating acute episodes of depression in somebody with bipolar 1 disorder, because SSRIs can actually make a bipolar patient manic. So we don't tend to use SSRIs in our bipolar patients. TCAs have also been used to treat migraine disorder, urinary incontinence, ADHD, obsessive compulsive disorder, diabetic neuropathy, or panic disorder with agoraphobia. Patient teaching, we want to make sure that patients are not taking in alcohol when they are on TCAs. We want to make sure they understand the risks and the benefits of the therapy, and that the full therapeutic effect actually takes several weeks. And we don't want them to abruptly stop. We don't want them to mix this with a lot of over-the-counter drugs without seeking approval first from their prescriber. Excessive exposure to sunlight, heat lamps, tanning beds could actually cause burns or hyperpigmentation of the skin. If they're diabetic, they need to monitor their glucose level carefully, because the TCAs can alter it. And they can really cause some severe dry mouth. So we need patients to maybe chew sugarless gum or suck on ice chips, hard candy, or use artificial saliva or biotin drops. And there are a few outlier drugs that don't fall into any of these classes, like trazodone. You should know things about trazodone because it can increase serum levels of digoxin and phenytoin in your patients. If it's used with antihypertensive drugs, it could actually cause hypotensive effects. And there's also CNS depression, which would be enhanced if trazodone is administered with another CNS depressant. And bupropion, which is also known as Wellbutrin, it doesn't fall in that SSRI, TCA, or MAOI category. If it's combined with levodopa or with TCAs or phenothiazines, it can actually increase the risk of seizures. And there are sometimes some cases where we wouldn't use it. Well, we wouldn't use it in seizure disorder at all, but we also wouldn't use it someone who had maybe like an eating disorder as well. And then we have lithium. And lithium, the exact mechanism is largely unknown, but it does regulate catecholamine release in the central nervous system, which would then increase norepinephrine and serotonin uptake, and it would reduce the release of norepinephrine. And it inhibits norepinephrine's action in that postsynaptic neuron. So it's used for treating mania and bipolar disorders. Your big things to know about lithium is that it has a very, very narrow therapeutic threshold. It can be highly toxic or too low of a dose. And to get into that little sweet spot, it can be very hard to keep in that therapeutic index. A blood level that's even slightly higher than the normal can be extremely dangerous and can cause death. And serious interactions with other drugs can occur because of this narrow therapeutic range. So anything that could slow the GI tract down could be a potential cause of lithium toxicity. Popular weight loss drugs, for example, that slow the GI tract down could cause an issue with a patient's lithium. And so the prescriber will be ordering serum lithium levels on their patients. So make sure that this is something that you are aware of if you're working in long-term care, that you know what your patient's lithium levels are before you administer that medication. The risk of lithium toxicity increases when lithium is taken with loop diuretics or any NSAID drug, even over-the-counter ibuprofen. Administration of lithium with haloperidol or carbazamine can actually produce an increased risk of neurotoxicity. And lithium can increase the hypothyroid effect of potassium iodide. Sodium bicarb can increase lithium excretion, which will reduce its effectiveness. And lithium's will also be reduced if it's taken with theophylline. If a patient is on a very salt-restricted diet, they're actually higher susceptibility for lithium toxicity. On the other hand, an increased intake of sodium can actually be therapeutic for a patient that is on lithium. So common adverse reactions to lithium include ECG changes, increased thirst, which if the salt levels are off, they could definitely have excessive thirst. They can get polyuria and they can get elevated WBC counts. And then when we talk about antipsychotics, there are two major groups. We have atypicals and typicals. And atypical antipsychotics are drugs designed mainly to treat schizophrenia. And they can include like clozapine, olanzapine, risperidone, quetiapine, riprazole. Those fall into that class. And then drugs that alter the P450 enzyme will alter the metabolism of these atypical antipsychotics. So it's very important that patients let all prescribers, no matter where they go, if they go to urgent care for a toothache, they need to let everyone know that they are on this medication because a lot of antibiotics will fight for that same enzyme. Like olanzapine, for example, if it's taken with Cipro, it can actually increase the amount of olanzapine that's in the bloodstream. And if you take erythromycin or fluconazole, ketoconazole with quetiapine, it will actually decrease quetiapine's clearance from the body. And if ariprazole is taken with fluoxetine or ketoconazole, it can increase the ariprazole levels and actually result in toxicity and damage to the body. And thanks for tuning in, and that was your lecture for week 3.